cytology basically.
You're doing cytology. So in cytology, we know about the conventional pap smear and we know about the liquid-based cytology. So which one are you using?
Conventional pap smear, and those patients who can afford, we are getting the liquid-based cytology also from them, but that is done from outside.
Outside. Your center doesn't have the liquid-based cytology. So I think that is one important thing, that most of the centers are still relying on the conventional pap smear. So is that so for all the other panelists also?
Medical colleagues from Meerut, and we are also using like pap smear and VIA. Firstly, I am prefer this VIA thing. HPV and these things are not available in the.
That's okay. We are just talking about what is available. So are you doing VIA and pap smear in all cases?
No, we are using basically first is VIA. Pap
Okay.
smear reports are most of the time these are not very good.
So
and
you are doing
based cytology is also
Alright.
we are not doing.
You are not doing. So you are
but
mainly
VIA
doing
is the
VIA.
first thing. Yeah.
Dr. Urvashi?
We are from the same institute.
Okay. Dr. Shazia?
We are doing the basically.
You have got the liquid-based
For
cytology.
thesis purpose, we are doing HPV DNA
Okay.
and VIA colposcopy test.
You are doing HPV DNA also.
For the thesis purpose.
Okay, leave that part. So, yeah. So I get this from this group of panelists that we have somebody doing VIA, we have somebody doing pap smear, and we have somebody doing liquid-based cytology also. So let me just ask, what is the main advantage point of one above the, like those who are doing VIA, what is the best part of VIA?
Actually, for VI we are using acetic acid which is available easily. We can make it in the OPD, and as the patients are coming in all age groups, we can use it as a screening test. And as if we find some abnormal tissue and abnormal report, then accordingly we can further proceed for the management.
Right. Any disadvantage of VIA?
Disadvantage, sometimes we are not able to see the transformation zone and the limit of the VIA which is going inside.
So what we know, yes, it is a simple test, it can be done, but this is particularly useful in the community settings where we do not have any laboratories, we do not have any tests available. In the institute settings, it will take some time. So that is another thing, somebody has to sit and do it, and then so maybe in your busy OPD you may not be able to do that. So that is how you have to decide that what method to be used where. So for community settings, of course, this is the best method. And then we have the pap smear and the LBC. So since you are doing LBC, what is the advantage of LBC over?
We get the cells that are settled down. The mic is results are very well interpreted with the LBC as compared to PET.
So basically they say that the, for the cytologist, a sample that is come through the liquid-based cytology is a better sample because you don't have that blood and mucus and anything, artifacts that are there. So that's the advantage. So if you have that machine that you can do LBC, it is better. But if you don't have, then you carry on with the conventional pap smear. So of course, coming to the HPV DNA test, which all of us know are the best test. And so I'll ask Dr. Urvashi, why it is considered the best test?
So because HPV DNA being a highly sensitive test, VIA and cytology are not as sensitive. So a negative test having a high negative predictive value allows us to increase the screening interval from 3 to 5 years. And now WHO in 2020 has even said that for general population you can do it 5 to 10 years because they have released the guidelines for general population.
So we'll be coming to about the frequency and all that will just come. But if you consider the method, the diagnostic accuracy of HPV DNA test is the best considering the sensitivity, and because we all know that it is the sensitive test which should be applied first as the screening test. That's the reason that it is considered the best test. So moving ahead to the next question which you just, okay, this was just telling you that what are the various HPV tests available. We've got some DNA tests, some RNA tests. Obviously we don't have much, so I don't want to talk about it much. But the simple kits that we have, the NATs, the nucleic acid amplification test, through which we have done the COVID test. Let me tell you, they should be useful for doing the HPV DNA test also. Although people do not know very well how to use them. Maybe in coming times that will be the most cost effective method of doing the HPV DNA test, and we are waiting for that. Now coming on to the screening protocols that you all are using in your centers. Dr. Aruna, I'd like to ask you, VIA, how frequently will you advise? Suppose today you do VIA and it is negative, when will you call her again?
Basically, VIA, we have run the patient for our complaint, so we are using it as a screening. And if it comes out to be negative, it is repeated after 3 years.
You repeat it after 3 years.
If it comes out to be positive, then accordingly we have
Then
to go.
obviously you treat it,
Yeah.
that's different.
Yeah.
So that was for VIA, for pap smear and everything.
Pap smear we are doing it every 3 years.
Every
There's
3 years
validity
again
for
you are
3
doing it, and HPV DNA if you do, as you said, 5 years you can.
5 years.
So here I would like to just put up these guidelines. These are the recent guidelines, WHO 2021, and very simplified. The best part is, so HPV DNA test when you are doing, you do from the start, from the age of 13. That's the right thing. And then frequency, you can make it every 5 to 10 years. In fact, WHO says you do just 2 lifetime tests, that is one at 35 years, one around 45 years. That should be good enough as a screening method for the community, and you should be able to pick up most of the women with the pre-invasive lesions. So advantage of the HPV DNA test is this, that you increase the frequency, you reduce the frequency and you increase the interval, and so overall cost benefit you will get. So it will be a cost effective test. अभी लगता है कि महंगा है, but अगर आप उसे करेंगे ज़्यादा frequency पर, so it will become less costly. So coming to the next question, I'll ask Priyanka to take over.
So, we all know that HIV positive women or women suffering from HBsAg or who are immunocompromised, they are susceptible to malignancies. So, how is screening different in these women, if I may ask? Dr. Poonam, would you like to answer?
Guidelines are different in WHO and Oncology CA. Now, Oncology CA says that as soon as the HIV is diagnosed, you should start screening. And if it is being done with pap smear, it has to be done with HPV. And it's to be done. And WHO says that at the age of 25, patient is HIV positive. You should start the screening at 25 years of age and 3 years to be done.
Any information about if we are using HPV DNA?
Yeah,
in
with HPV
HIV?
DNA then 3 to 5 years.
So the point that we want to actually highlight is that for HIV positive women, you start early and you do it more frequently.
More frequently and for a longer duration. Another thing is that any woman who is diagnosed with CIN or carcinoma cervix, we all do virology, but this is an identifying malignancy also for HIV. Works backwards also. So the mechanism that, okay, we go on to the next case. This is a 55-year-old lady who presented with postmenopausal bleeding, and she was menopausal for 5 to 6 years. And it was just a spotting, and she consulted a practitioner who advised a pap smear, which many of us are doing. The report came out to be ascus. So what do we tell this patient, and do we do anything more for her?
So, for this patient, when the report has come ascus, now we all know that after the ALTS trial, the best way to triage an ascus smear is you do a HPV test. And if the HPV is positive, we go in for a colposcopy, and if it's negative, you can repeat the co-test or the pap smear at 1 year. However, if the HPV DNA test is not available, or if you feel that the patient is not compliant, you can even go straight away for a colpopapsy. Like in our center, we have patients who are coming from the rural setup, we don't have HPV DNA. For all ascus, we do a colpo-directed papsy, give them a green chit, and then they can go back to their villages, because we have seen when once the patients leave our setup, they don't come back. So you have to, tailor the guidelines according to your setup, the patient profile you are dealing with. If you're sitting in a private setup, definitely you can go in for HPV.
Same thing, if ascus came up in post-menopausal, we will go for colposcopy, and accordingly the treatment. If this colposcopy comes to be negative, then we have to repeat the HPV DNA, and accordingly it comes out to be like, and colposcopy is the must basically, should be done.
Yes, so there will be centers where even colposcopy is not available. So VIA also.
Why?
And non-compliance is an issue.
Yeah, there is
evaluations.
problem with VIE in the postmenopausal female as transformation zone goes
Yes.
inside. We cannot see properly.
Yes.
That's why colposcopy is the gold standard for these
If it is not available, we can do a VIE.
That is.
We can also do the HPV DNA.
HPV DNA is definitely the gold standard. Needs to be triaged with it. But when it is not available, as we saw that most of us don't have that facility. So we do a colposcopy, even if that is not available, we can do VIE.
So you can repeat the cytology also, and again if it is showing, and then go ahead for it if she is not ready.
We can also wait for this patient.
Yes.
We can counsel and ask her to come back after a year and repeat the
If
cytology.
you are sure she'll come back after.
Yes. So when not
That's
compliant,
right, that's very
if compliant, can come back after 1 year with the cytology.
But important message here is that she should not be scared of, you tell her that this is some kind of cancer. That's what happens. Patients come to us कि ये आ गया है, hysterectomy कर दीजिए, uterus निकाल दीजिए.
That is true for all
That's
screening tests.
Yes. That should not, especially these from LCL onwards, we will always say that you must do a colposcopy. But then, yeah. Okay.
So the HPV came out to be negative, and the consultant also thought maybe we should do an endometrial thickness assessment. So that was also done for this patient.
So is it important? We are on the last.
Yeah.
Is
So
it important
pap
to
smears or smears, can they detect endometrial cancer?
Definitely they can, but if the patient has an episode of postmenopausal bleeding, then we should go in for a TBS to detect the
Yes.
endometrium. And even if the patient endometrium is thin, but the patient is having postmenopausal spotting, that is an indication for endometrial sampling. It's very important. We should always remember for our PGs, we are not treating the report, we are treating the patient. So if the patient is saying she is having postmenopausal bleeding, even if your ET is 2 mm, you have to do a sample.
But we heard in the morning also that if it is single episode and the cell is less than 4 mm, then it is very less 1% chance that it will be. But
Chances
if
are
they-
good.
repeat
Maybe also with trophic endometritis it
Yes.
can go.
So let's go the next step.
So as most of our panelists agreed that we can do colposcopy. So I think we went on to do a colposcopy next. And any one of you would like to describe what we saw? The picture. Is it adequate, the colposcopy? Are we able to see the
We are
transformation?
not able to see
the
the
whole of cervix?
transformation.
Are we able to see the whole of cervix? Because as per IFCPC, the whole cervix is visible and there is no scarring. Then it's an adequate colposcopy. Any comment on the type of transformation zone? We are not using any manipulation and we can't see the columnar epithelium. So probably a type 3, or maybe if any manipulation could help, then maybe type 3. And the kind of epithelium that we are seeing, so it's pale pink and thinned out, goes in favor of atrophy, and acetic acid is already applied. And can we see any well-defined lesion on this anywhere? Yes. No lesion is seen, but there is a generalized whiteness, pale pinkness, and there is no lesion. So these are typical findings of a postmenopausal cervix, which often when some consultants find on colposcopy, they think there is something wrong and they want to take biopsies.
Yeah,
So
this
anyone would want to take a biopsy in this patient from anywhere. Is there any indication for biopsy? There is no indication for biopsy.
ECG we can go for, but
ECC because the upper limit of the transformation zone is not.
So if we manipulate and we're able to see it, then we don't need to. So that is not in
I think important message for the audience is that since you do not have any distinct opaque white lesion, so this is just a generalized very light whiteness. It is not an aceto-white lesion. So it is that's what the important.
Probably we have the cause for the spotting as well over here. We have some petechial hemorrhages because of atrophy. So this patient had atrophic cervicitis. And since there is no lesion, so there is hardly any scoring required here. So obviously the score is somewhere around 1, which is like non-existent. So here's a sweet score we all know, but I think this would be relevant if there were a lesion. I could have described it. But for the information's sake, we mark the margin of the surface of the lesion, the kind of acetic acid uptake. If there is light acetowhitening, which is described typically as milky white, then it is scored as 1. And if it is distinct, opaque and dense white, it is scored higher, which is 2. margins, if they are well defined and not geographic, which means if they are not irregular margins like they will be in a body lesion, then you score them higher as 2. But irregular geographic margins are described as or given scored as 1, which goes in favor of benign lesions. Vessels, if there are no irregular vessels or if there are fine, well branching vessels, they are scored lower, whereas coarse atypical vessels are scored higher. Lesion size, if it is large, less than 5 millimeter, not significant, 5 to 15, involving more than at least 2 quadrants is low grade. If it is involving 3 or 4 quadrants and is more than 15 millimeters, then it is a high grade lesion and we score them higher. Iodine uptake, definitely if there is distinct yellowing, that means it's a well defined lesion, it is a higher score lesion. So this was atopic cervicitis, and we treat these women with topical estrogen, which often many consultants don't advise. They just counsel and leave the patient. The significance of giving vaginal estrogen is a bit lost on us. So I thought we'll discuss this.